This is in contrast to this case where there's an obvious avulsion in the distal interphalangeal joint, the DIP ulnar collateral ligament, with this area here being the middle phalanx, this being the distal phalanx, this being the ulnar collateral ligament. If you keep your eye on this area, the distal end of the middle phalanx, as we scroll through the dynamic test, you'll see this area of cortical irregularity open up. This patient had no real improvement after 4 months post-injury. He came, we performed 4 treatments of shockwave therapy over 4.5 weeks, with which he was very happy with his improvement, and he's now climbing pretty much normally 3 months later. Now we're just going to have a quick trip down into the lumbricals, and where we can see the cursor here, that's where we started the first demonstration with the pulleys. This is the A1 pulley, that's the metacarpal head, so that's the first, that's the line of the metacarpophalangeal joint there. As we keep them in long axis, the flexor tendons in long axis, we go proximally into down the palm. We can differentiate between the FDP and the FDS. The literature doesn't have any mentions at all about flexor injuries, flexor tendon injuries in this part of the hand. In our case study though, we'll see a massive tear in the actual flexor tendon of the FDP in about this area through here. Now we can take that right down, and then we take that into short axis, so that we have the third flexor unit here and the fourth that's going to the ring finger, and in between we have the lumbricals attaching to the FDP. You can see how that disappears, and we really don't have the clarity to be able to differentiate the structures. I've never been able to follow the lumbrical to its distal insertion on the radial aspect, in this case of the ring finger's dorsal hood. But there's no swelling, there's no view of any muscular damage. And in this area through here, if you're suspecting an injury, then you can perform a dynamic test. So pull that finger up against me, harder to the ceiling, pull, and now the middle finger, and you can see the tendon structures moving just through this area here. Pull up, but everything is stable, and if there's an injury, you're likely to actually see some instability in this region. This type of injury doesn't seem to be represented in the literature at all. It's a longitudinal tear of the flexor unit at the level of the metacarpal. This is actually the ring finger, so it's at the level of the base of the fourth metacarpal, with the left side of the screen up here being distal, this side being proximal. And one can certainly see movement through there on the dynamic test. This was taken 4 weeks post-injury. This is the same patient in short axis, this being ulnar, this being radial. We have FDS here, FDP in this area. One can see an unstable segment of the FDP just there. There was some debate with some colleagues of whether it could have been a lumbrical tear, with the lumbrical obviously sitting here attaching to the FDP. Our evidence that we've produced in a further slide showing collagen formation, which is likely to be in the FDP, really does support a flexor tear in this case. 3 months on, there is evidence of fibrosis, of healing in the flexor unit seen through here. Training has progressed. We wait to see if the area is actually stable enough now to resume full intensity climbing. Now this is a totally different type of injury. This is the index finger. This is the ulnar sagittal band. This is the radial sagittal band. This is the extensor tendon. So it's in the region of the dorsal hood of the ring finger. This climber was out running. He came around a bend really fast and his hand punched into the wall just on the inside with a lot of force. Initially, we expected this to be a rupture of the radial sagittal band, which is one of the most common pathologies in this area, but our dynamic tests show that the area was stable, but there was just significant effusion from the metacarpophalangeal joint. So we diagnosed a capsular tear, and we've got that labelled up through there. And we predicted that 2 months' time, this should have healed significantly so he could increase his training, and this is actually what happened. And the longitudinal shot through there. We're not going to be covering the extensor anatomy. If you look at the referenced YouTube video at the end from Fajardo, ultrasound of the finger, that's a fantastic reference. So there's a few examples of some injuries that you can see in fingers. Hopefully you found the case studies interesting. Now it's actually time for you to give it a go.